I've tried to extend that argument beyond just health to economics, basically showing the amount of economic loss it causes to the populations and governments across the world. And despite the size of the problem, how governments are not spending enough towards mental health, and how global development agencies are not spending enough towards global mental health. This is the background on which I want to talk to you a bit more about my topic, which is innovate or stagnate. So what I'm going to talk about is basically set the scene a little bit when it comes to mental health in terms of the burden and the existing solutions. So what's the problem, what's the size of the problem, and how the world has decided to respond to it? And what are the problems with those solutions, which is the stagnant bit of it? How we can change some of this by innovating. And finally, I would like to end by doing a little bit of crystal ball gazing and looking forward to what we could do to change some of the issues that we're experiencing when it comes to increasing access to mental health care for people who have mental health problems, not just in low resource settings, but across the world. So the size of the problem, and you must have gathered it based on the questions and the responses that you gave, indicates to me that most of you very clearly understand how big the size of the problem is. If we can look at it from different perspectives. We can look at it from the perspective of mortality. We can look at it from the perspective of morbidity or disability. And the most commonly used metric these days to identify the burden or the size of the problem or the disability that a problem causes is something called as DALYs, or disability adjusted life years. So at last count, we were seeing that mental health problems account for a large proportion of disability adjusted life years. Even amongst all health problems, approximately 1 out of 6 life years lost to disability comes from mental health problems. Considering the number of health problems that are happening across the world, if we can say that 1 out of those 6 disability adjusted life years are contributed to by mental health problems, it tells you the size of the problem, even within the frame of reference of larger health issues that the world is experiencing.
Dr. Abhijit, could you speak a little bit slower, please? Thank you.
Okay.
Interpretation.
Shifting the frame of reference a little bit from disability and burden to economics. What is the economic burden to the world because of mental health problems? At last count, it accounted for around $5 trillion a year. If we want to look at this from the perspective of the developing world, and frame it against the GDP of some of the countries that we're talking about, then in Eastern Sub-Saharan Africa, the costs due to mental health problems are 4% of the GDP. And in high-income countries, they are 8% of the GDP. The bottom line being that mental health problems not only contribute to poor health, but also cost not just the individuals and families, but societies large amounts of money. So there's an economic argument for why we should be responding to mental health problems across the world. So let me expand the argument a little bit more, because if you remember what I said at the right at the outset, we don't want mental health and the response to mental health to remain only as a health systems response. And the reason for that is there are a huge number of social determinants associated with mental health problems. These social determinants can lead to mental health problems, and mental health problems can lead to poor social outcomes. So it's a bi-directional relationship between social factors and mental health problems. And what are these social determinants? They affect various aspects of people's lives. So, for example, work, so being unemployed, or employment that is not confirmed or sure that you have a stable employment over the next year or few years. You might have a job, but have poor working conditions. Poverty within society at an individual level, which might be low income, but also systems which lead to food insecurity have been shown to be associated with poor mental health. And vice versa, if you've got mental health problems, then your employment opportunities go down, and so your income goes down, which in turn can have effects on your food security. Discrimination in various forms, racial, ethnicity, immigration status, sexual orientation, has a poor impact on mental health. Problems in relationships, violence, abuse happening within families and other relationships, and expanding this to the wider community. So, for example, rapid urbanization, neighborhoods which are unsafe, neighborhoods or communities where there's a lot of violence. All of this have an adverse impact on mental health, and mental health can lead to some of these outcomes as well. So we have to remember that mental health is not just an health issue. It affects all of us, and we should be involved, all of us should be involved in responding to it, not just health systems. So traditionally, how have we been responding to mental health problems across the world? We could break this down into who delivers interventions for people with mental health problems, where they are delivered, and what is delivered. Coming to the first one, who delivers mental health care? In the traditional conventional systems that exist across the world at the moment, mental health care is delivered by highly trained specialist mental health professionals like psychiatrists, psychologists, psychiatric social workers, etc. Where they deliver these interventions? They deliver this primarily in clinics and in tertiary care settings, all of which are usually urban-centric. And what they deliver is medications and high-intensity psychosocial interventions for people with mental health problems. Now, the issues with all of this are basically poor accessibility, because across the world, most of the settings in which mental health care is delivered are inequitably distributed, primarily in urban centers. We do not have enough specialist mental health professionals across the world to deliver the interventions. And the high-intensity psychosocial interventions and medicines, many of which have to be taken for a long term for people with mental health problems, are extremely expensive. And because of these major barriers, what happens is that a large proportion of people with mental health problems across the world do not have access to any kind of mental health care. So broadly, if 10 people have mental health problems, only one of them has access to some kind of mental health care. I'm saying some kind of mental health care, mind you. I'm not even talking about high quality, evidence-based mental health care. Just getting some kind of mental health care is so difficult because of all of the barriers that I spoke about, that 9 out of 10 people with mental health problems do not have access to mental health problems. These numbers might vary slightly depending on which part of the world you are in, and even within countries, there are variations. But broadly speaking, even when we talk about developed countries, we know that access to mental health care is poor. That's the problem. It's not enough to just state the problem, right? Because that is stagnation. We are thinking about innovating to overcome this problem. And what is this one innovation that I'm going to talk about? There's this one innovation called task sharing, which has a long history. I mean, it's been used in the space of global health for many, many years. I mean, starting off with maternal and child health care, then HIV, tuberculosis, etc. And is now also being used very efficiently and effectively for delivery of mental health care. Task sharing basically means that you are rationally redistributing frontline healthcare tasks, in this case, mental health care, to people who are non-specialists, who have limited training and supervision to deliver frontline mental health care services to people with mental health problems. This model has been shown to be effective. It works. It's inexpensive because you're delivering it using non-specialists. It is scalable because you have large number of healthcare workers who are not specialists and are delivering care for other conditions. They're contextually more appropriate because these people are usually people from the communities and are more accessible and familiar to people to whom they deliver the interventions. And they're less stigmatizing because they don't come with the usual labels that accompany mental health professionals like psychiatrists. Various parts of the world, including the developed world, in Africa, in Asia, and in South America, and has been shown to work for a range of mental health conditions, common mental disorders, depression, alcohol problems, depression in the elderly, maternal depression, etc., delivered in a range of settings like primary care, community, secondary care, etc., by a range of non-specialist health workers, from nurses to primary care physicians to community health workers to volunteers and peers, who have done task sharing of various different activities like identification of people with mental health problems, providing psychoeducation, providing frontline psychological interventions, supporting people in adherence to treatment. So a whole range of different activities related to mental health care can be task shared to relatively inexpensive and more easily available community health workers and other non-specialist workers. And who are these people? These are people who do not have any previous healthcare training or experience. So for example, in some of the work that we have done here in India, our non-specialist workers have been people who have worked as shopkeepers, housewives, accountants, salespersons, who have had no training to deliver any kind of healthcare interventions, let alone mental health care interventions. What is required is short, well-organized trainings to help them build up their competencies and skills to deliver the interventions. But what is also more important, in combination with the training, is rigorous supervision. What we have realized that just training people to go and deliver interventions leads to a rapid stagnation and decay of the skills that they develop. And for them to maintain and continue developing those skills, they require rigorous supervision. Well, you might say that this is a fantastic idea, but at the end of the day, the proof of the proverbial pudding is in the eating. And this is just an example that I'm going to show you of some work that we did in India. This was a trial, a randomized control trial, in which we trained lay counselors, people from the community, the kinds that I spoke about earlier, to deliver an intervention for alcohol use disorders. We compared this with enhanced usual care. So what was usually happening in the primary healthcare centers in terms of delivering care for people with harmful drinking. We enhanced it by helping the primary healthcare physician with knowing the diagnosis of people with alcohol use disorders. And we compared the two in a randomized controlled trial. What we found at 3 months was that this intervention that we delivered through task sharing was superior to enhanced usual care in leading to remission, as people no longer having alcohol problems, abstinence, people stopping their alcohol consumption completely, and the proportion of days that people remained abstinent. Very interestingly, these positive findings were sustained at the 12-month outcome evaluation as well. So these were not just early findings, we were able to sustain these findings over a longer period of time. More interestingly, we also trained these same non-specialist workers to also deliver a counseling intervention for people with depression. So these non-specialist workers were not delivering counseling only to people with alcohol use disorders, but also to other people who are having depression, basically showing that lay counselors or non-specialist workers can be trained to deliver various different kinds of mental health interventions. And it's not that they can deliver only one. And this was the first time someone was able to demonstrate that we can train non-specialist health workers and task share various different activities with them at the same time for different disorders. So finally, I want to end with this slide, which is what I think we should be doing as we move forward. And we kind of package this under an acronym called Sundar, which in our vernacular language in Hindi, in India, means beautiful. But basically the acronym stands for simplifying the message. What do we communicate to people with mental health problems and their families and communities about mental health problems? We need to move from making mental health a complex, jargony field which people do not understand to something that people are easily able to understand. Second thing is we need to unpack some of these very high intensity, complex interventions that have been primarily developed in high income countries and identify what are the basic core components of these interventions which will lead to change so that we can convert them into low intensity interventions which can be delivered by non-specialist health workers. Third, we need to take these interventions out from the clinics, we need to take them out from the hospitals, we need to take them out from tertiary care settings and take them to the communities as close as possible to where people live so that access to mental health care is increased. We need to leverage the human resource that is available in local communities and task share with them to increase access to mental health care, just as I have shown, but not just in healthcare settings, but also in communities through peers, volunteers, other kinds of workers like teachers when you want to deliver mental health care interventions for young people, etc. And finally, when this saves you money, because a lot of the frontline tasks are being done by non-specialist workers, you reallocate the scarce and expensive resources which are no longer needed or needed in a lesser intensity, like the time of the psychiatrists, psychiatric social workers, hospital beds, etc., reallocate them so that these people can focus on training non-specialist health workers, responding to more complex cases, supervision, monitoring and evaluation of programs, etc., so that there is more effective and rational use of these limited resources that we have. With that, I would like to end. I just want to kind of stress on the takeaway message, which is mental health is a huge problem across the world. It should not remain a problem of the health systems or healthcare workers. It's a problem which all of us should be responding to. There are huge problems with access to mental health care. And if we want to overcome the barriers to mental health care access, then we need to be thinking about innovative solutions, one of which, there are many others, one of which is task sharing to non-specialist health workers, because it's effective, it's efficient, and it's inexpensive. Thank you very much.